Okay, hello and afternoon, everybody. Welcome to the Innovation in COVID-19 Patient Pathways webinar hosted by the Oxford Academic Health Science Network. My name is Meghana Pandit and I'm the Chief Medical Officer at Oxford University Hospitals. I'm going to chair this webinar alongside Dr. Andrew Brent, who is a consultant and lead for infectious disease at Oxford University Hospitals. We have fantastic speakers this afternoon and we have until 5:30. We have plenty of time for questions and answers, and that'll be at the end of each speaker's talk, but also at the end of all the talks. So really this is COVID-19, and all of us have gone through the last 6 months, shared many experiences and worked extremely hard. And here we are talking about patient pathways again. And what this is, COVID-19 has done is it has really forced a re-engineering of healthcare in all healthcare settings, and in many ways accelerated years of change in the NHS that sometimes takes a long time. So optimizing clinical systems and enabling patients to self-monitor to aid the early identification and timely management of deteriorating patients in the community is a critical step in avoiding and reducing deaths in all conditions, not just COVID. So supported by a regional deteriorating patient group, this webinar brings you examples of innovative ways to assess and manage patients in the community with suspected COVID-19. Just a little bit of housekeeping before we start. A reminder that this session is being recorded. Please use the chat function for questions throughout. Andrew and I will keep an eye on it, and we will start the questions at the end of each talk, and then you'll have plenty of time again at the end, as I said. And there are many attendees, more than 200, so we've kept the videos off and muted except for the speakers. So I hope you will understand the reasons for that. So I'm just going to briefly introduce all our speakers, and thank you to all of them. First speaker is going to be Dr. Matt Inada Kim. Matt is an acute medicine consultant on a 50-bedded acute medical unit at the Royal Hampshire County Hospital and clinical lead for sepsis and deterioration for the Wessex Patient Safety Collaborative, and also National Clinical Advisor on Sepsis and Deterioration. Matt was a Harkness Fellow at the Commonwealth Fund and traveled and studied other countries' health systems as well. He has also worked as a GP. Dr. Lalita Iyer is an executive medical director at the Frimley Collaborative and clinical co-chair of the BAME COVID-19 pilot in Slough. She will follow Matt with an outline of the pilot virtual ward project and experiences that they have had in Slough. Lalita is a GP partner in Slough since 2007. She has a special interest in obstetrics and gynecology and is the women's health lead for the Slough CCG. She has been the pediatric lead for Slough CCG and was involved in pediatric asthma to improve the health of children with asthma. She has led on various cancer-related projects for Slough and was involved with the Macmillan Cancer in their project on promoting increased screening uptake in Slough. She has been awarded the Queen's Award for voluntary service. Our next speaker, Dr. Andy Walden, is a consultant in acute and intensive care medicine at the Royal Berkshire NHS Foundation Trust. He is an honorary senior lecturer at University of Oxford and research lead for the Thames Valley Critical Care Specialty Group. He has a research interest in emergency medical care and point of care ultrasound, and has recently set up the Acute Internal Medicine Point of Care Ultrasound Academy. Andy will share the triage into community COVID-19 assessment and management in ED and GP Hot Hub. Professor Dan Lasseson is Professor of Acute Ambulatory Care at the University of Warwick and clinical lead for ambulatory outreach team at Oxford University Hospitals. And he will share his work on the point of care ultrasound in the ambulatory care setting, including in care homes. Dan has been clinical lecturer and researcher at University of Oxford since 2007 and is now the only UK professor of acute ambulatory care at the University of Warwick. With Hospital at Home clinicians across the UK, he has set up the newly formed Hospital at Home Society. And our last speaker, last but not the least, needs no introduction. It's national and internationally well-known Professor Trish Greenhalgh. Professor Greenhalgh is a professor of primary healthcare sciences at University of Oxford. She will update us on RECAP, which is Remote COVID Assessment in Primary Care, an assessment tool that provides an early warning score. Trish is an internationally recognized academic in primary healthcare and trained as a GP. She has been instrumental in providing rapid evidence review on COVID-19 related topics. So I'm going to make a start with Dr. Matt Inada Kim to begin this webinar. Thank you. Matt, over to you. You've got 15 minutes.
Can you see my screen?
Yes.
Fantastic. One sec, let me start the show. So really nice to meet you all, and thank you for tuning in. So as said, I am an acute physician and former GP, and that's probably the best that I can do as a descriptor. All through COVID, what we learned was the importance of oxymetry and about spotting the silence of symptoms associated sometimes with really bad outcomes in COVID. Time and again within the emergency department and acute medical departments, we saw patients with very low oxygen saturations, blue in fact. And this absence of symptoms coined the phrase silent hypoxia, something we'd only previously really seen many years ago with PCP and various other HIV-related illnesses. And even political commentators like Peston spotted this early with this pretty good article in The Spectator outlining just such a sorry tale of a poor man who contacted the NHS on 3 occasions, but because he wasn't breathless, was not assessed by pathways and protocols that existed at the time, and unfortunately died a few days after his partner was admitted via ambulance, hypoxic and breathless. So I'm very much of the belief, working in hospitals and across the interfaces, that the battle for this is going to be won in the community. This is about what general practice does. It's about what the community does and how much we can empower patients with the ability to spot sickness and badness in their home environments to ensure they are best prepared to seek help early so that we can draw attention to them and admit them where that's appropriate at the earliest juncture, because there are treatments that help this condition. And what will save lives is not ventilators necessarily, but the alignment of our systems and how they work and interact with each other. Our own performance through first peak could have been better as a country. Our case fatality was high for a number of reasons. We only did tests on those admitted, being one of them. But equally, we know from international studies that the more prioritization there was on oxygen saturation readings, and the higher the level at the admission point, the better the country did on the whole. We know what we're about to face also in this country in winter and autumn, and we hope that it won't replicate what we saw with 1918 flu, but we must prepare for the worst and hope for the best. So from a national perspective, thinking about how COVID presents in all settings, we need to try and think about how we align testing, potentially biomarkers, respiratory panel testing, and clinical assessment, and potentially oximetry within drive-throughs and other mechanisms in the community, in hospital-led clinics and outcomes, and potentially within the ambulance service, to think about how we ensure we don't miss patients who are sick for other reasons, because COVID is not everything to do with deterioration. And then how we do that risk assessment and decide who needs that more close follow-up, that virtual ward follow-up, versus those who potentially just need safety netting. And thinking about how that works in all settings. Our clinical strategy is clear. It needs to be aligned in terms of the models of care in all environments, a joined up community ambulance and hospital interface, and how we use and think about remote assessments. To the words that Meghana just said, we have been forced to re-engineer healthcare. Changes that would have been taken 20 or 30 years in the past have been done in a series of months. And thinking about how we embrace this opportunity to really embrace patient care at home in a way that patients want, to pick up silent hypoxia and other things, to safety net patients and empower them with knowledge, and think about what digital supporting technology and innovations that should be there to bridge the systems and the divides and the silos of healthcare that exist. The evaluation is critical to this, and we have some great minds on that, including Trish, as well as Aradazi and Naomi Phillip, trying to bring together what learning points there are going forward from this model. And then if this is the right thing to do, how we scale and spread at scale, at pace, in order to be ready for winter. So the pathways were the first step, and we began with the emergency department pathway, followed it up with the primary care, then the care home pathways, all leading into the COVID virtual ward. So if you're not admitted through those pathways, you go there. And we tried to use the same lines in the sand, and this was made without strong evidence at the beginning. It was an iterative world right at the beginning of first peak. We had to start with something. And for us, there were clear boundaries of using oxygen saturations and NEWS2 together with risk factors, and then the introduction of the 40-step desaturation test. Something we saw time and time again within clinical practice has been quite a useful guide as to whether someone has COVID or not, actually, and whether they would be safe at home. This was supported then with the sit to stand 1 minute test in addition, and Trish and others wrote a very useful paper in CBM that outlines the methodology of that. The importance of oxygen saturation readings has come to the fore, and some work between South Central Ambulances and my own trust has looked at around 2,300 admissions, of which 1,100 were definite confirmed COVID cases, and then looked at the 30-day mortality rates at different oxygen saturations. We need to get this published, obviously. And what we found is that actually those boundaries of 93, 94, 95 to 100 and less than 93% were quite good lines in the sand. Rather a high mortality at less than 93% if you come into contact with an ambulance assessment, at nearly 28% mortality at 30 days, dropping to about 13.4% mortality if you're in the 93 to 94% band. So it's important we use this data at scale and look at it also within different departments. And this is data from the Royal Free, thanks to Tara Sood and her colleagues, that shows very similar. So as soon as you hit that less than 93% band of oxygen saturations, your mortality is pushing 30%. Information that we really need to base potentially our future pathways around. So the primary care pathway had the same lines in the sand as the secondary care lines in the sand. And it's really important to emphasize that alignment, to all be on the same page, to reduce the confusion. And then the evidence and the pointing towards personalized care, because that is a key element as well, because not everyone needs the same treatment or indeed warrants hospital admission if that's not in the interests of the patient or indeed with their wishes. The care home model is very similar, same lines in the sand, augmented by the use of soft signs deterioration as being the entry point. So what people really say when they become ill, as exemplified by the Restore 2 nursing home chart that I hope you're familiar with. Again, the same lines in the sand as to who gets admitted and who doesn't. And then thinking about things more broadly, how we define the COVID virtual ward is really important. In a minimum of words, in a framework that is simple and is understood by healthcare professionals and patients. And for us, and we kind of coined this phrase at the Patient Safety Leads meeting yesterday, it describes this enhanced package of monitoring, both of symptoms and oxygen saturations for patients at future risk of deterioration or admission, provided in the patient's own home, managed by either community or hospital teams. So that's a simple working definition that we've coined so far, and we're very grateful for future comments on this and how that evolves over time. So the what in terms of the pathway itself really revolves around patients from the community and the hospital sectors being joined up with a similar kind of diagnostic and follow-up and monitoring approach. With the high-risk patients, so those who are older, BAME, obese, comorbidities or lots of medications, having a more active follow-up, and those who are younger and fitter having a more passive follow-up with just safety netting. And thus far, some of the pilots have been using different forms of daily follow-up. And in our case, it was days 2, 5, 7, 10, 12 post-onset of symptoms, with a follow-up call at day 14 to evaluate the project. And that evaluation is really important. The majority of pilots have used 3 times a day monitoring. And so far, we have utilized the enthusiasm of this to acquire around 200,000 oximeters, with a plan hopefully to acquire more. Safety netting guidance nationally is being constructed as we speak. And the diary is in paper form at the moment, although app designers are creating the same. And the diary itself is as a mechanism for recording symptoms as well as oxygen saturations over time that is really ripe for demonstration and production into apps. We've produced animations in different languages as well as English to really guide patients as to what COVID is about, what to look out for with COVID. And also that has been translated by colleagues into different languages. And it's really important we do that. Equitability. These are resources for all cultures, not just those who speak English. And we need to get this right, and right first time. So Accurix have produced some pretty good apps that encompass this diarising of symptoms. And I know other app designers have done similar, and this is just one example. But what's really important and what it shines a light on is the need for interoperable digital systems, not only within the COVID pathway, but for all cause deterioration. And thinking about how we build that future model of healthcare, how we actually build a fit for purpose digital system that actually looks after entire regions' healthcare needs from cradle to grave. So the animation itself is pretty self-explanatory and really worth a look, and we can post links to that in due course, and talks people about the mechanics of how to use an oximeter and the danger signs to look out for. What's really important within this model as well is actually thinking about the virtual ward and how it maps with time periods and what happens 9 to 5 Monday to Friday, perhaps not happening outside those hours, because the working week is long. It's 168 hours and not just 9 to 5 Monday to Friday. So we need to nail this properly, and we need the digital interoperable systems in each region to encompass that safely. When we inject a model like this, it's important to look for balancing evidence. Has what we have done caused excess work that we didn't mitigate for? So South Central Ambulances did this wonderful pilot from the beginning of June to look at what the injection of oxygen saturations would be and have on the call demand for 111999 and category 2 ambulance calls. And thankfully, it hasn't increased the numbers, which is great. And a really important and sensitive part of this, because you can't just inject these things and think that everything will be fine. There are lots of unforeseen circumstances that need to be mitigated against. And the scale and spread for us has involved thinking in my patch of the spread from 4 sites, 2 general practice hot hubs of 200 to 250,000 populations each, 1 hospital trust involving 3 sites covering a population of 570,000, and up to 600 care homes, to think about how we put these principles into action to safeguard patients. And thus far, out of the monitored patients, and we have 130, we have reasonable data from the entire pot of 2,000, there have been 0 deaths. Pretty staggering stuff, actually, in the context of a case fatality rate of 14.4% during first peak. And our aims are obviously to get that evaluation done at scale, because that monitoring feels like the right thing to do. And the question is whether we can do this and, times 150 across the whole country in due course. In terms of, I guess, where we go from here and the learning points, if I had my time again, I guess this is what I would think about in terms of that COVID virtual ward strategy and what would needs to be engaged in terms of partners, collaborators, the collaboration, consensus and compromise that's required, and how we align commissioning, measurement and system-wide alignment in the medium and long terms. And the surveillance data is not pretty, and we know we are peaking again. And whether this is now the critical juncture in your individual localities and regions to start seriously considering this implementation, and how we do that using patient safety collaboratives or academic health science networks to form delivery groups and develop implementation strategies. Think about pathways, borrow, beg and steal, and join the national community of practice and then go on to help others, because there's a lot we can do here within this. To think about using our virtual ward learning network, we have 75 regular members now, and Joe Murray is a key lead within this. To think about how we spread knowledge at scale over many thousands using social media, using videos, YouTube, and share the learning. There's no guardedness about this. We need to share at scale. We're in an adaptive world, an iterative world, and keeping data and evidence to ourselves is going to help no one. So this forum that we formed, again, you're welcome to join, has about 550 members so far and shares all the resources known to anywhere in the world about COVID and how you manage people in both inpatient and outpatient settings. So ping us an email and let us know if you want to join. It's something we hope to build on in due course. And finally, we need to really think about the what next. Winter is coming, whether we would like it or not. And the commissioning behind our systems and how our systems work in each region is really important. I think we need to up the ante in terms of our public-facing campaign to empower patients in terms of knowledge, as well as tech where that's appropriate in how that all works. And to start planning early in terms of what that COVID virtual ward looks like in each region. And to think about how we can support a model that involves that community hot hubbing and potentially an all-in-one version of testing, to think about testing as well as clinical assessment, as well as oximetry, to safeguard the health of our population.
You have 1 minute, Matt.
Thank you very much.
Excellent. Thank you very much, Matt. Okay, so we will look for some questions to come in, but before then, let's get Dr. Lalita Iyer to talk about the Slough Wave 1 project. Over to you, Lalita.
Thank you. I'll get Joe to present my first slide, please. So thank you, Matt. Interesting presentation, as always. What I hope to do in the next 10 minutes is to give you all a flavor of what we've been doing in Slough. So next slide, please. So the Slough pilot epitomizes joint working. I don't want to read the entire aim of the pilot, which is in front of you, but essentially it talks about the NHS working together with the local people, the voluntary sector, public health organizations, and the idea behind it was to empower our communities so that we have a holistic approach supporting the population of Slough. This project is chaired by myself as the clinical chair and Tracy Faraday-Drake, who is our local managing director for Slough. And it's unique that she is a joint appointee between the CCG and the local authority. I wanted to just point out the rainbow on the right that you see, and that is our strategic ambitions of the Frimley ICS. And it was felt right at the start that this pilot focuses on the well-being of our people, that's ambition 2, and also focuses on tackling health inequalities. It also focuses on our people, and we made a conscious effort in this pilot to include the workforce component of the work that was happening within the ICS as one of our work streams. You see the 5 work streams alluded to on the left of the slide here. 2 of them are clinical, that's the prevention and harm reduction, and the clinical management of the patient when they get infected. And the rest are about communication with the community, improving information such as ethnicity data within GP notes, and so on. There's a map of the Frimley ICS for those of you who aren't familiar with Slough, and I'd like to point out that Slough is the tiny little area at the top right of the Frimley ICS. And it's also interesting that the population of Slough is the same as the population of Windsor and Maidenhead put together, a much larger area as you see below. Next slide, please. So we already looked at how Slough is significantly more densely populated. And I wanted to share some of the key facts about Slough, which puts the things in perspectives in my remaining slides. So we know that there are increased rates of COVID-19 impacting the BAME population disproportionately, regardless of what you correct for now, and that's national data. Slough has more than 50%, 54% of its population fall into the BAME category, and that's a 2011 census, and I would suspect that's much higher now. We also know that deprivation is common in Slough, and if I could ask you to look at the chart on the left of the slide, it shows you how most of our residents, 60% of our residents are between decile 2 to 4. Those are the most deprived deciles. We do not have anybody in decile 9 and 10, unlike other bits of our ICS. I also wanted to point out to you that in Slough, 1 in 6 households have no member speaking English, and 27%, or almost 1 in 6, are recorded as not speaking English as first language. So the language barriers that we hear about are actually real, and we feel it in day-to-day clinical practice as well. I wanted to just quickly highlight to you the prevalence of various clinical conditions in the second chart that you see in the middle of the slide. So we know, and Matt alluded to this as well, that conditions like hypertension, diabetes, and so on, and obesity are associated with higher morbidity and mortality from COVID. And The bar chart there, the light gray dot without the light gray bar without the numbers are for the rest of the ICS, and the dark superimposed ones with the numbers next to them are for Slough. So we see a deprived population with language barriers in really crowded areas, also having a lot of morbidity and clinical conditions which affect their health. And therefore, in the early part of the pandemic, we did see a disproportionate number of deaths in Slough. The other single key factor that I want to just touch on before we move on from the slide is multi-generational households. So it's not uncommon in Slough to see parents living with their children, but also looking after their parents. So there could be 1 or 2 sets of grandparents living in the same household. The household is not really very big. And therefore, if one member gets infected with COVID, perhaps the younger person who's been mobile and going out, they pass it on quite easily to everybody in their households. And the vulnerable elderly then are at a lot of risk. Next slide, please. So this just touches on our clinical management pilot, which I lead on, which has as its part the preventative outreach, which we're mainly focusing on improving the conditions such as diabetes and hypertension. But I'd like to focus today on the active home monitoring and the virtual ward. We started the pilot in Slough as a regional pilot for the Southeast, but then the clinical arm has become one of 3 national pilot sites. And it is a proud moment for Slough that we're able to participate in this. And right at the start of this pilot, even before we were national, we had decided that although this was meant to be a pilot for the BAME population, we did not want to create further inequalities, and everybody in Slough who is high risk was included anyway in the pilot. Next slide, please. So as soon as the guidance was released from the National Virtual COVID Ward, as Matt alluded to, the first thing I did as medical director for the Frimley ICS was aligning our Frimley guidelines, which were slightly different to what was proposed nationally. For example, we had a 5% drop with exercise testing, but we changed it to 3%. So conversations with our consultant colleagues at the Frimley Park and Wrexham Park site ensured that we aligned our pathways to this. And I just wanted to very briefly touch on the pathway that exists in Slough. So unlike some areas in the pilot where GPs are responsible for the oxymetry in the timings of 9 to 5 in the daytime, essentially, we had a hot car service provided by our out of hours provider already in Slough. So we merged the pulse oximetry onto our hot car provision. So the SOP just was easy to fit in. So when a patient contacted the GP through 111 or directly through the practice, the GP triaged the patient, but was then, the patient was then handed over to the service of the hot car. The hot car then would go and assess the patient, and if they were mild, as in the green box there, then they just had an oximeter dropped off, information on oximetry, certain videos, etc., on explanation on how to do this, and the patients were then followed up daily by this same team. And if the patient continued to be stable, they were monitored daily and discharged around day 14. If at any point the patient, and I must add here that the other thing we incorporated was swabbing the patient. So when the hot car went in early on, around day 1 or 2, when the patient made contact with us, all of them had COVID swabs. So it ensured that the swabbing happened at the right time and patients did not miss having swabs. And if the patient deteriorated or was in the moderate category right from the start, then the hot car assessment would decide if the patient needed to be transported to ED or does the patient need just more enhanced monitoring. And we used the 3% drop exactly as in the national guidelines. And of course, the severe patients ended up in ED, and ED were also aware that they could discharge them back into the community, into the virtual ward. The referrals, as it says here, were taken in the daytime between 8 in the morning and 8 at night. Next slide, please. So what we also did was to streamline our communication with patients. I've given you a background of the population of Slough, so it was extremely important that anything we put in place needed to be communicated to patients, as Matt said, in a way that they understand. We also found that when patients speak a language, for example, if they spoke Polish or Punjabi, it didn't mean that they could read the language. And therefore, we focused on creating videos because everybody understood the language if they were able to speak it. So we created videos, about 2-minute YouTube videos, which is available on the Futures website. And in fact, as I speak, by end of this week, we would have 2 more languages, Tamil and Somali as well, available in those videos. We also created our own virtual ward monitoring form and the remote COVID diary, which essentially took out the essential bits from the national document that came out in a easy read way for our patients. Next slide, please.
Alita, you have 1 minute.
Okay, thank you. So this is just some data that I wanted to share from our virtual ward dashboard. So we had 43 patients, currently 12, and this is the referral data from, source of referral. Next slide, please. So I just wanted to point out that out of 43 patients, 19 patients came from 4 households, just showing you that multi-generational families are extremely common in Slough. Next slide, please. So a case where I just wanted to share this case study with you, where we have 7 members in the family, 2 grandparents, 2 parents, 2 grandchildren, and an aunt in the annex self-isolating. The index case of referral was actually the 66-year-old grandma who had multiple comorbidities, wheelchair bound, and when the paramedic went to see her, we heard that the whole family was actually ill. So all adults were recruited into oxymetry. Grandma was admitted around day 3 due to deteriorating SATs, no symptoms at 93%, and unfortunately passed away in the hospital. Mom then told us 2 days later that she was actually pregnant. This then stimulated us to work with our obstetric colleagues to create an SOP for all pregnant women with anticoagulation. Next slide, please. The second case of note was a woman who had her husband die at home, witnessed cardiac arrest at home. The wife and son were asked to isolate after the death certificate is issued as COVID NP. Mum clearly was extremely anxious, went across and self-presented after a swab positive on the 13th of July. She ended up self-presenting for further swabs herself. And while we were monitoring her in the initial phase, we noted that the child was bradycardic, and the hot van dispatched the child into the hospital. Both are well and recovered, I'm glad to say. Next slide, please. Feedback has been great from patients with our service. The main issue we're finding is that the population of Slough seems to be a little bit reluctant to use digital modalities compared to paper. There's a little bit about digital literacy, I guess, to consider, but there's also a feeling that the human contact of a phone call every day seems to be preferred. Next slide, please.
Lalita, last slide, please.
Yeah, so this is Mum who died. One more slide. I just want to focus on a little bit of, so we had a number 10 Downing Street task force visit who came in because the numbers were slightly rising. But by the time they came, numbers had gone down because of collaboration, partnership working. And next slide, please. And communication was thought to be the key aim. And I just want to say that regardless of what we do clinically, we must also remember to make, next slide, culturally appropriate communication for our population. Thank you so much. And
thank you very much. Thank you, Lalita, and thank you, Matt. So we have some questions coming. And I can start with the first one, which is about pulse oximeters. So clearly there are loads of commercially available pulse oximeters. Is there any approval process for these, or how reliable are they?
That's a good question. I'm not a technical person in terms of knowledge about the relative merits of oximetry. In terms of the presence of CE kite marks, one would hope there would be an element of quality control in them if they possess that. But others on the call may have more knowledge. And the second thing to say is there were some papers that were published within the past 5 years that assessed the veracity of pulse oximeters, very cheap ones, and found they weren't that bad. They struggled at the lower regions, so the very low levels of oxygen saturations, so the extremes, but actually were pretty good for the general run-of-the-mill kind of values. And let's be honest, if you've got SATs of 60%, you're coming in. There's no discussion about that. So I think they probably do have a place, and it's a good question. We need to do evaluation at scale. Most of the 200,000 we've bought have all come through procurement. So they've all been sort of tested at source, but obviously we can't speak for everything on Amazon.
Thank you. There's a question here about how Lalita dealt with the non-English speakers in Slough, and I think you've answered that, Lalita. A question from Andrew Brent. Andrew?
Yes, thank you. Can you see and hear me?
We can hear you. Carry on.
Brilliant. I'm very interested in the experience, Matt and Lalita, that you've had already, and in particular how patients have managed oxygen saturation monitoring at home, because anecdotal experience suggests that that's not always straightforward. You can, even in good hands, get readings that vary considerably over time. So how have you managed sort of the odd isolated low reading, and how have you managed the potential anxiety that might go with that in patients who are monitoring and recording these things at home? Has it exacerbated the anxiety that is already present in many of the patients who've got COVID and are worried it's going to get worse?
Matt, do you want to go for it? Or
yeah. Oh, you're very happy to. Just to say, from the anxiety perspective, just to answer one question at a time, certainly within the pilots we ran, and there's 130 definitive patient feedback forms we've got from the ones in my patch. We had one patient who got more anxious as a result of it. So that was a specific question we put within our patient-related feedback. 129 did not. And to be honest with you, we could have predicted that one person right from the start. So, you know, there is a certain amount of horses for courses in it from that perspective. And in regard to the first question and the fact that there's going to be the odd reading that's abnormal, and we don't want people phoning 999 for, you know, within 30 seconds of getting a one-off bad saturation. So what our amazing AMPs did was they talked patients through it. So when they were low, it was a question of, are you sitting down? Are your hands warm? So everything in the video, really, have you been resting? And then repeating it. And if it was a sustained low oxygen saturation, then they acted. And usually we brought them back to our SDEC, so our same day emergency care clinic, to give an eyeball and see how they were doing.
Thank you.
Thank you, Matt. And just as a follow-on question from that, how did that work out of hours? Because obviously your AMPs were available in hours, but I'm guessing it might not have been a 24/7 service. So out of hours, how did that work? Was it NHS 111? And what would you think about the impact going forwards at scale that might have on other services? Obviously NHS 111 was overwhelmed in the first peak.
Yeah, and just to follow up on that, so you're right, it's an important consideration, which is why we did that SCAS trial of, you know, giving people oximeters. Has it increased the number of calls? And we found in practice it didn't. Just been given the opportunity to create an educational program for the whole of CCAS, and you know, essentially we'll be looking at giving pretty cast iron solid advice over how to interpret oxygen saturations and to do those pragmatic things that our nurses were doing in terms of the clinical response. So it's not just a one-off oxygen saturation, but actually it's also a degree of symptoms using clinical judgment, you know, all the things that we have in spades and should never forget. And in ensuring we do the best with what we have and what we can do remotely within the circumstances that we face.
Thank you. Lalita, just one last question for you before we move to our next speaker, which is about collaboration and cooperation with and from the CCGs. How has that been for you?
Yeah, so because we are 3 CCGs within the Frimley ICS and we have a common executive team, we haven't found any problems because I work as a medical director for all the 3 CCGs. So the members of our CCG, all the primary care members, know that the Slough pilot is going on while we changed our guideline, and the reasons why we changed the guideline. The national guidance was shared with everybody in GP bulletins, but also in webinars locally. So they are also waiting for the national analysis of the data that the team are looking at, as Matt alluded to, in order to see whether oximetry is useful. And I'm sure it'll come out that it is useful.
Thank you very much. Thank you both, Matt and Lolita, for some fantastic work that you've demonstrated here. Okay, so we will move on now to our next speaker, Dr. Andrew Walden, and he's going to talk to us about assessment and management in ED and GP Hot Hub. Over to you, Dr. Walden.
Okay. Thank you for asking me to talk. So yeah, I'm Andrew Walden. I'm a consultant in acute medicine and intensive care medicine at the Royal Berkshire Hospital in Reading. And I'm also the lead for our ambulatory care unit. And I'm going to talk about a virtual ward we set up called the Triage into the Community of COVID-19 Pathway. So we looked with great concern at what was going on in Italy in February, and through several WhatsApp groups, we got in contact with actually a gentleman here called Cristiano Pirani, who's an ED consultant in Brescia. And they'd reached the point where they actually were having to pre-triage in a tent in front of their emergency department. And so we're having to find very innovative ways of trying to work out who they could send home and who they needed to bring into hospital. And they shared this pathway with us. And a couple of weeks later, we were kind of wondering what was going to happen in Reading. Were concerned that actually there's no reason why what was happening in Northern Italy couldn't be happen in the UK. And so we decided that we were going to try and set up a similar pathway and a means of virtually following up and monitoring patients. So myself, Joseph Noonan, who's one of the acute medicine fellows, and David Clark on the right of the screen, who's one of the ED consultants. We managed to get two of the midwives here who are Italian to translate the pathway. We put it through several iterations of a kind of virtual clinical governance in acute medicine and emergency medicine. And then we went up and spoke to our Chief Operating Officer, Dom Hardy, and our Chief Medical Officer, Janet Lippett, and basically punted the idea to them and said we thought that this was something that was going to be a really good way of stopping the hospital from falling over. And they supported us, and they gave us permission to purchase 500 saturation probes and some handheld ultrasound machines to help get this service up and running. And it was, it was an amazing experience really, because as we all know, the NHS can be incredibly bureaucratic, and the pandemic really showed how the NHS can work well when everyone pulls together. So from concept to implementation, I think it was 5 days in total. So it was really quite a remarkable achievement. And there are obviously lots of other people involved in that, which I'll come to at the end. So this was our pathway, and I'll just talk you through it. So patients who presented to the emergency department with COVID, obviously if their saturations were low, depending on the severity of their saturations, they would then stream onto 2 inpatient pathways, so they'd be admitted to hospital. The patients we were interested in were the patients with normal saturations, and these patients then would undergo 2 further diagnostic tests. So they would have some form of imaging, because what we really wanted to do was identify patients who had COVID pneumonia rather than just patients who had a COVID viremia or upper respiratory tract symptoms. So they would have some form of imaging, and then they would undergo a rapid walking test. And again, this was not a particularly evidence-based thing, but it was just what they had been doing in Italy. And we marked out basically a 30-meter walk in the stat bay of our emergency department. And patients would do this, and if their SATs dropped by more than 5%, then that was felt to be a positive test. And if they dropped by 5 or less, it was felt to be a negative test. So this then streamed through to 3 potential scenarios. So scenario 1, where the imaging was normal and the walking test was negative, it was felt these patients were probably in a low risk group, and they would be discharged with some safeguarding advice and instructions to call 111 if they got worse. Scenario 3 was the other extreme, where it was patients whose SATs had dropped by more than 5%, and really regardless of what the imaging showed, we felt that these patients should then stream onto the yellow pathway at the top, which is what they did. But then scenario 2 was the ones we were interested in, where they had good evidence of pneumonia, but their rapid walking test was negative. And these patients would then basically be given a saturation probe, would be given an information sheet and links to some YouTube clips to show them how to check their SATs, and would be referred to the ambulatory emergency care unit electronically for follow-up the following day. There was also a rider for the patients in scenario 1, so those in high-risk groups. so with lots of comorbidities who were felt to be vulnerable, could be referred onto the virtual clinic by their clinicians if they had concerns. So this is how we ran it. So there were a whole load of physician associate students who'd been in their final year, who'd been sent home from their course, who were absolutely desperate to get involved. And so they all actually ran and did all the phone calls with the patients at home. And then we were fortunate enough to have 3 furloughed ED associate specialists who, because of felt to be in high risk, had been sent home from the emergency department. Again, were desperate to be involved, so they acted as a kind of clinical supervision. And then, as I say, I have to give a lot of respect to Joe, who really day to day ran the project, because I was up on ICU for a lot of this time. So what would happen? So the patients, as I say, would get rung by the physician associate students, and then would stream into a similar algorithm actually to the original one. So they would go through a set of scripted questions, and then they would get the patient to check their saturations. Those with low saturations, or significantly low saturations, would be told to ring 999 and return to the hospital. Those with normal saturations and who didn't drop when they were told to do some exercise would be reassured, and they would be then checking their saturations regularly during the day, 4 times a day, and then would be rung the following day. And those in the middle scenario 2, where they had normal saturations, but then actually when they did some exertion, their saturations dropped by more than 5%, were encouraged to come back to the hospital, but in a more controlled fashion rather than just ringing 999. So there were several iterations. It started out as an emergency department only thing. We then brought in the GP hot hub, which I'll mention in a second, and also allowed patients who had got through the net and got into acute medicine to be referred on, and also some ward step-down patients where their SATs were still perhaps a little bit low. Clinicians were worried and they wanted some form of follow-up. We also introduced some other iterations. So we managed to get a pharmacist, so where patients hadn't been given antibiotics, when they'd gone home, we were able to actually do that, and also saturation probes as well. And we had a phone available 9 to 7 days a week, 9 to 4, 7 days a week for patients who were worried. I think this was perhaps one of the things I was most proud about, because I've tried for years to try and kind of interact better with primary care, and this was really an amazing initiative by the Reading and Wokingham general practitioners. So they set up a hot hub in central Reading and donated staff from each of the practices, and basically directed all of their primary care suspected COVID patients to this hot hub. And again, a testament to times COVID. This was from inception to implementation was I think 8 days from having the idea to actually getting it set up. Really quite phenomenal. And again, their pathway is very similar to ours, except that they would actually do the walk test first as the patient arrived. And then depending what that showed, if they failed their walk test, or if they had low SATs, they would just be sent straight up to hospital. And then, but the group who didn't fail their walk test would then have some ultrasound lung imaging and would enter the pathway in a similar way to the one from ED, as you can see on the bottom left here. This was, again, another fantastic part of it was that we managed to implement something, some high-tech kits. So we had these point-of-care ultrasound devices, which we trained the GPs up on in half a day, which sounds sort of like not enough, but we had, one of the best things about these was that we had access to a cloud, which the GPs also had access to. So we could actually review their scans real time, and so add an extra layer of confidence and governance about what we were doing. So in fact, we ended up admitting about 300 patients to this ward, but when I last analysed the data, this was towards the end of June, and at that point we'd had 244 patients referred onto the wards. 226 patients had been discharged, 11 were still under review, and 7 were still in hospital. 29 of the patients had to re-attend ED, and 7% had to be readmitted. And this was more through serendipity than anything, but this was we were quite proud of this, because NHSI and the Ambulatory Emergency Care Network suggests that an optimally functioning ambulatory pathway should have a conversion rate to admission of around 10%. So as I say, it was more through serendipity than anything, but that our pathway worked very nicely in that respect. And we did have 1 death and 3 ICU admissions, but again, when you consider that that was in out of 300 patients, then yeah, very sad, but a very low number. Just some demographics. So we had a wide range of patients. So the median age was 49, but we had an 18-year-old and a 94-year-old on the pathway. Predominantly females, again, because the males tended to be sicker and needed admission to hospital. And although you see the GPs only referred on 45 patients, they got up and running after the emergency department. And actually towards the end, they started to kind of accelerate. So I think in the end, we had 60 referrals from general practice on the pathway. I put this slide up and because I think one of the things we were concerned about that a news might actually overcall things in these patients. Most of these patients were going to deteriorate due to hypoxemia, which is why we concentrated on measuring their SATs. And the national guidelines, probably about 40% of the patients we sent home would have been recommended or possibly recommended to be admitted with news scores of 3 or above. And this was the differences between the 2 groups. Obviously, this wasn't statistically powered beforehand, and none of these distances are statistically significant, although as you can see, if you're a man, you were more likely to be readmitted, which is kind of what we would expect. We took some patient feedback. We've actually up to 185 patients now, and overwhelmingly, they would have recommended this service to their friends and family. So this is reflected in the larger numbers as well. And just coming to the point earlier, some of the discussion, I mean, we overwhelmingly, again, the theme we had was that patients felt they felt very scared actually from having COVID. And they felt that this service was very, very reassuring. They found it reassuring to have a SATs probe, so that if they got a fever or they felt unwell or tachycardic, at least they had the reassurance of being able to put the probe on. And if their saturations were okay, they felt reassured. And then obviously having the ability to ring through to a service and not have to go through some bureaucratic system to get a consultation, they found incredibly reassuring. And we did some cost-benefit analysis. So this was predicated on a £200 per bed day, and it was a cost avoidance model. And even allowing for, initially the PA students did their service for free, but even allowing for the fact that they then ended up getting paid, we worked out that we saved the hospital about £106,000 per month. Which obviously would have carried on if we'd carried the 640,000 over 6 months if we carried it on.
Well, one final
I don't know how much time I've got left, but just the last slide really, I think the thing that more than anything I'm proud of actually is how many other people were involved in this. And you know, this was really a team effort. So, you know, information governance, the information governance team, medical physics to allow us to get the probes up and running, you know, all of the clinical staff, but also our executive. I mean, they were incredibly supportive. We had a bit of a sort of block around trying to get the money released for the SATs probes, and they were all incredibly accessible, and we were able to go up and just speak to the finance manager who unblocked it once we explained what was going on. And so that's me really. So I'm going to stop there and open it to questions.
Thank you very much, Andy. That was a superb demonstration of how ideas that begin at grassroots levels can actually be very, very beneficial for patient care. So there's a question here from Benita, which I will start with. In previously fit patients, was the walking test enough exertion to cause desaturation, and how does it compare to 1 minute sit to stand?
Well, obviously at the time that we set this up, we were, you know, there was no real evidence for a 40-step test, a 30-meter walk test, or a sit to stand test. So we just had to choose, because as I said, we did this in 5 days. So we just had to choose one that fitted our purposes. It happened to be that the stat bay was exactly 15 meters. So we chose 30 meters for that reason. And I know there are discussions about which test might be a better stress test. I mean, my understanding is that a sit to stand is probably more of a stress test. But again, this was a pragmatic approach. This was, you know, I put my hands up. There was no real evidence base around this. This was done preemptively in a fairly expectant way that we were going to really struggle, and we needed to have something that worked. And as I say, regardless of which test you choose to use, the pathway was successful because, as I say, our conversion rate, our readmission rate, you know, if it had been 0, then you could have said, well, what was the point? And if it had been 50%, then it would have been unsafe. Whereas actually, again, just through serendipity, really, we chose the right test.
Thank you. Andrew, any questions?
Thank you. Andy, really lovely presentation and a really impressive body of work. I'm just interested in how you measure impact. Obviously, in terms of the clinical outcomes of the patients that you've seen, you've deliberately chosen the lower risk group of patients who aren't sick enough that they need to come into hospital. So wondered how you'd found comparators to assess the impact of your intervention. And then similarly on the cost benefit side of things, it's not inevitable that those patients would be in hospital. Do you mind just saying a little bit more about that?
So just to do your first question, just repeat that again. The impact relative to what? So
you shared a slide with the outcome of the patients that had been through your service,
yeah,
and showing that there was a low mortality. I think from memory, 1 patient died and 3 were admitted to ICU.
Yeah.
I suppose my question was, this was a selected group of patients who, when they presented, were relatively low risk, and whether you had any comparative data for a similar group of patients in another setting who didn't have that follow-up to see whether outcome was very different.
No, I didn't. I mean, as I say, this was done as a sort of service development thing. So we didn't, you know, in retrospect, it would have been nice to have done that, wouldn't it? Is to maybe randomize patients to either have the follow-up or not have the follow-up. I mean, there's other aspects to it. There's softer aspects, aren't there, as well, Andrew? So, you know, the patient experience side of it, as I say, I haven't gone into great depth of that, but we have done several interviews, and we're doing some qualitative sort of follow-up with one of the qualitative researchers here to actually try and, you know, dig a bit deeper into what patients' fears were and how perhaps the being on the pathway benefited them. One of the patient groups that it definitely did really benefit, and who we got some very positive feedback from, was staff members, because overwhelmingly staff members did not want to be admitted into hospital to be cared for by their fellow staff, and so they really appreciated the fact that they could just go home, and, you know, we involved occupational health with us as well, so, you know, they were very much on board. So yeah, so I don't know is the answer.
So I wasn't in any way undermining what you've done with my question.
No, sure.
I think it's fantastic work. But the other question, and you may have said this and I missed it, was about the cost benefit. Again, it wasn't obvious to me that.
No, and you're right. So retrospectively, actually, when we looked at how the hospital coped with the first wave, the peak of the first wave, a significant portion of these patients probably could have been admitted. So, you know, obviously we've done a cost avoidance method, but, you know, I mean, you know, it doesn't mean that you're going to be able to shut wards anywhere. It is just a way of gauging whether it was reasonable value for money. And yes, so in retrospect, I think if we admitted all these patients, then we would have been struggling. We probably could have omitted 50% of them and actually probably been okay. But again, it's not just the absolute numbers. Actually, at the peak of when we were running this service, we were actually following up 45 patients. So, you know, that is potentially, if you'd admitted all those patients, that's 2 wards of patients, which, you know, when you think about the staff that you would need to manage a ward like that, and the knock-on effects it has on the rest of the hospital in terms of flow and things like that, it's you know, again, it's not particularly evidence-based, but it's kind of common sense that must have helped to a degree.
Okay, thank you very much. We will move on now to Professor Dan Lasserson, who is going to talk to us about assessment and management in ambulatory care. Over to you, Professor Lasserson.
Thank you, Megan. That's just
Andy, would you switch your camera off, please?
Oh, sorry. Yeah.
Thank you.
Okay, can you see my see my screen? Is that all right?
Yes.
Fine. Okay. So thanks very much for asking me to speak. So I'm the clinical lead for Hospital at Home at the John Radcliffe, and also an academic in the West Midlands as well. And I lead on the acute care interfaces themes in the applied research collaboration in the West Midlands, based at Warwick. I'm presenting some work that was done with the research and clinical team I'm working with at City Hospital in Birmingham, as well as my growing a research group and clinical group at the John Radcliffe in Oxford. So, and this kind of follows on nice, I think, from Andy's talk about how we are evolving the role of point of care ultrasound in that ambulatory care setting, and particularly around risk. So what is point of care ultrasound? I slightly hesitate to follow Andy. Andy's obviously a big national leader in ultrasound in the UK within acute medicine. So I sort of like hesitate to speak, given that he's a much better expert than I am in this. But essentially, point of care ultrasound is a complement to the clinical assessment. We're not replacing radiology or formal ultrasonographic exams. We are asking a specific clinical question and using the ultrasound probe to do that. In the setting of the lung, prior to COVID, some of those questions were generally around: is there interstitial fluid, usually due to pulmonary edema? Is there consolidation, or is there a pneumothorax? Is there a pleural effusion? And also to guide procedures. And the picture that one would see from a normal lung ultrasound looks a bit like this. So obviously it's very different to a chest X-ray because we are essentially looking at a different modality. And that's so the pleura is seen as a shiny, nice shiny white line in health at the front. And then if the lung is dry and there's no abnormality in the lung pathologically, then you see what are called A lines, which are generated by reflections between the probe and the pleura, almost like harmonics, if you like. And those two dark areas either side of those white stripes are shadows from the rib, which obviously absorbs the sound. So essentially we can look at a lung, and what was emerging at the time when COVID was being initially described from the experiences in China was that there was a sort of a characteristic picture from lung ultrasound in COVID. And those of us that were following this, there were some webinars from that early experience in China, mainly from the ICU setting, but increasingly from acute medical settings as well. There are also pocus trained physicians who were monitoring their own recovery on Twitter and posting their own pictures from doing their own ultrasound scans daily. And some emerging protocols from emergency departments in Italy as well, as Andy's already talked about. So this has sort of exploded on the scene from a number of different sources, not just from published evidence, but also from the more sort of grey literature and social media as well, which has been incredibly helpful in disseminating rapid learning in the first wave of the pandemic. And our question really was, can the lung burden of disease as assessed by POCUS, can that predict outcomes? And obviously a whole value of point of care ultrasound is this is something you can do anywhere. And my interest in ambulatory medicine and out of hospital care and hospital at home is actually taking this ultrasound and complemented clinical assessments in the acute care pathway, both in and outside the hospital. So what does a COVID lung look like on ultrasound? Well, there's a lot more fluid inside a lung that's been affected with COVID, and these are what's called B lines, and these are lines that go from the top of the pleural line there all the way down through the field that you see from the ultrasound. So the ultrasound probes are held near the skin, and there's the pleural line, and then those sort of sunlight rays, if you like, coming down from that pleural line throughout the rest of that lung field. And there are many of those in the patient with COVID. Also, another feature in COVID is an irregular pleural line. So we've seen that normally there's a nice thin white crisp line, the pleura, but patients who have COVID within their lungs, and often this pleural line is seen quite irregular. And it's sort of broken up and it's a bit thickened. And then as patients develop to a consolidation, those consolidations are quite peripheral. You see them next to the pleural line. So obviously having peripheral disease, which often sees on CT scans, that's really amenable to altering what that ultrasound picture looks like. So just to describe how we set about exploring what that degree of change on lung ultrasound could help us in terms of clinical decision making. These are patients who were with a suspected clinical diagnosis of COVID by the ambulatory and acute medical teams at City Hospital in Birmingham. And as we know, like many major cities with a very diverse population. Birmingham was hit very hard in terms of numbers of patients and also the outcomes and the risk of the patients seen with COVID. So this was a standardized protocol for pocus. So those of you who will be familiar with the blue protocol, we know there are 3 zones, 2 on the front of the chest and 1 at the in the axilla, and so 3 zones per lung, so 6 zones in total were acquired in a standardized way across all these patients, and we either used a GE, logic, or a butterfly IQ. In Andy's talk, he showed how the butterfly IQ is used both in and out of hospital with the GP hubs and on his acute medical unit, and we found it to be a really useful point of care ultrasound thing for us, because it's portable, plugs into a phone, and we can take it anywhere. The pleural and interstitial changes were graded. A little bit more about that in the next slide. And we collected outcomes that were delivered from routine care. So whether the patients went to intensive care, their lengths of stay, oxygen requirements, and mortality. Sorry, I'm not sure what's happened there. Let's just go back and try and reconnect. Right, okay. So this is how we grade it for the study. So as we top line through the interstitial changes, so we're based on the number of B lines, or whether they coalesce to form essentially what looks like a big fan coming out, if they've all coalesced together. And then the pleural changes were graded, whether it's normal, whether irregular, or whether we saw those subpleural consolidations just under the pleura. So essentially the scores were added up, so you get an overall aggregate score for each patient. And so in each of those 3 zones on both sides of the lung, there'd be a score that would be based on the interstitial change and also on the pleural change. So just looking at the patients that were included, so just under 100 patients we studied with ultrasound, that sort of within that ambulatory interface with the community. And so on the top line, we have the severity score. So these are just the numbers into there are 4 groups there, from low to high. And the mean age are pretty static across them. Admittedly, we don't have large numbers in each group. So I'll just describe the numbers as they are without trying to get too much in terms of the interpretation across the entire score range. As Andy pointed out in his data, we would expect more men in this hospital assessed population rather than a community managed population, and so across the severity scores there were more men in the higher severity scores. So the measure of inflammation, the CRP, C-reactive protein, in those with a lower severity score, the CRP was low, and then increasing with higher severity scores as assessed by this lung burden from our ultrasound findings. And as one looks at higher levels of severity in terms of change on an ultrasound, more and more patients were lymphopenic, but again, numbers are small at upper range. And just echoing Matt's thoughts on News 2 and Andy's as well. Certainly across the lower and mid severity ranges, not much change in the News 2, and obviously it's more the hypoxia and oxygen support that's needed rather than the totality of the physiology is measured by News 2. So as you say, it's not always the best guide. One of the thoughts we have is that maybe that if patients have longer illness duration, maybe there's a time effectively for a greater burden of lung disease. We didn't find particularly that those who had a longer duration of illness had more severe changes on their ultrasound. It was fairly sort of flat across those severity ranges. But I guess the key thing for me is thinking about how ultrasound could change management and could influence my sense of risk, is looking at what the outcomes were across those severity scores. So again, without wanting to infer too much, because it's a 100-patient cohort, I think that in the lower severity scores, the inpatient mortality was very low, and also a very low chance of clinical deterioration. So what we're interested, I guess, in 2 things, or I'm interested in several things. One is, can I send this patient home? And if this patient does go home, are they at high risk? Do you think there's a saturation monitor? And also, if this patient needs to come into hospital, what kind of bed should they have? And do I need to tell critical care outreach about this individual? So there's a sense of what is their risk, and also what's the likelihood of clinical deterioration as well. And in those higher severity scores, again assessed by the lung ultrasound, mortality was higher, but also the clinical deterioration in patients was much higher as well. So it effectively allowed us to calibrate a care model, if you like, from we think you can go home or you can go with monitoring all the way through to you're somebody that needs to be either near ICU or in an HDU environment. And that's just based on their lung ultrasound without any other parameters as well. We also looked at the clinical decision that was made just after the ultrasound. Essentially, could this patient be discharged? Did this patient need an increased level of care, whether that's to go to HDU or ICU, or whether this patient can carry on their current environment on the acute medical unit? And of the patients that were discharged, by and large, they had lower scores, and those who needed an increased level of care had increased scores. But again, we have a small cohort here, so we don't want to read too much in it, but there's certainly a signal that the totality of the burden of change as assessed through ultrasound may be calibrated with outcome. We're not the only ones who are interested in this, obviously. This is some work that's been done in Australia, and there's a number of groups globally that are looking at the value of ultrasound in terms of outcome and how it can contribute to management decisions around location of care particularly. And so here, this is a protocol suggested by an Australian group, the reference is there, and this is a consensus diagram. So they've got their lung ultrasound changes above there, which is probably a bit of, in hindsight, probably a simpler scoring system than we've developed, and a proposed protocol below it. But there's no patient data. This is a consensus documents at the moment, and they may be in the imminent wave that's coming. They may be putting this into practice and seeing how the extent to which it actually allows them to make secure location of care decisions and escalation of care decisions.
1 more minute, Dan.
Thank you. I'm nearly finished now. Last slide. So, but obviously we're just one site, and we're also contributing to a national collaboration, which is to pull these standardised POCUS findings and clinical outcomes from the first wave with the Focus Acute Medicine Ultrasound Society that Andy set up, as well as the Intensive Care Society through their FUSIC2 as well. So not just to map the utilisation of POCUS, who's been doing it, how it changes management, but also to continue the evolution of deriving scores to optimise predictive outcomes, and then say what does it add in addition to biomarkers or the physiology as well. But also, with my interest mainly around out-of-hospital care and ambulatory medicine, it's the questions we might ask in ambulatory care cohort may be different, obviously, from the questions that an intensive care physician would be interested in terms of how they would use lung ultrasound daily on their unit. I maybe want to isolate a group of patients where I can safely predict that they won't deteriorate based on the ultrasound findings, or they're very low risk, or even identify the group that actually, if they do go home, do need monitoring because they are maybe at risk of deterioration, which we like to detect earlier rather than later. And with the ambulatory outreach team, when I'm taking the ultrasound out into care homes, so in the first wave, and some of its use there is not necessarily in calibrating to risk, because for many of these patients, there's an existing care plan not to go into hospital, but it's also to make sure that we don't miss treatable causes of breathlessness in that frail group in care homes. So particularly, identifying pulmonary edema due to heart failure, and also more obvious sort of bacterial pneumonias as well, rather than COVID. So it's very useful in making sure that we can still give calibrated, tailored care to people where transfer to hospital has become complex because of COVID, so that they can still get their accurate diagnosis and accurate treatment wherever they are, particularly for that frail group. So thank you much for the opportunity to talk. And as this national service evaluation emerges, we hope to have a wider, better data set in order to try and understand a bit more about how tightly the calibration is between lung burden as assessed by POCUS, clinical outcomes, and how that can be used for clinical decision making. Thank you.
Thank you, Dan. Okay, if you will stop sharing your screen. Wonderful. Thank you very much. So we have time for one question, and then after that, Dan, there are some questions in chat. So if you wouldn't mind answering those, that would be very helpful. So question, Andrew.
Dan, thank you very much. Really interesting, and clearly putting POCUS on the map in 2020. One of the interesting things about COVID is the biphasic nature of the illness. And so it may be that you did present this data, and I was just struggling to assimilate it all in the limited time. But it's not inevitable that the predictive value of POCUS would be the same early on in the illness, shortly after the beginning of symptoms, as opposed to early on in the second phase of an illness when patients represent. Do you have any sense about what its prognostic utility is in those two different scenarios if you look at your data separately for the two groups?
Yeah, okay. So essentially we have by the time, so the cohort we had were referred in or had made their way into an acute assessment setting, and by and large they had at least 7 or 8 days of illness. So we weren't seeing patients who were sort of 2 weeks in of symptoms. There's between 8 to 10 days primarily. I think by the time when one looks at how POCUS is used in those settings, by the time someone gets somewhere, they have had a reasonable duration of illness. So I don't think there is any data out there very early on from what the lung looks like. It's only at the time at which people deteriorate to the point of coming for an acute assessment. So I think the data is probably biased in that sense that we only really have it in those who've had a reasonable duration of illness and they're heading towards potentially into trouble as things move on. And also, I think the setting in which you're seeing patients as well. So there's an ICU group of ultrasound findings in that broader national piece we're contributing to, and that'll look quite different to the acute medicine one as well. So both in terms of duration of illness and severity as well. So there's still a fair bit to tease out, but it is embedded and nested within a decision-making process. And one is actually what decisions does it change? Can you make a better decision with it than the one you can make already? And that, I think, is the acid test. And that may be particular population specific, whether that's ICU or whether that's ED or ambulatory medicine, or in patients who are on a COVID ward at home, and there's some access to them. But it's something, it has a huge potential in that patients don't need to travel into a central building in order to get some additional understanding of what's going on in their lungs, and that I think has a huge potential. But there are a number of things to sort of explore, so that can be delivered in a governed and standardised way.
Thank you very much. We'll be moving straight on to Trish and recap. Over to you, Trish.
For COVID-19. Now, if you remember back in March, April 2020, the pandemic hit the UK pretty quickly and pretty heavily. We had high and rising death rates from COVID, but also in some hospitals, certainly, the mortality rate was really very high. Not in Oxfordshire, but in some hospitals, they were actually recording mortality rates up to 33% on some days. And what on earth's going on here? But one of the things that might have led to that was late referral from primary care. Back in March 2020, I wrote a piece for the British Medical Journal along with my co-authors, and to be honest, we didn't really know what the key signs of deterioration were. So this was an article in the BMJ that it had more than 250,000 hits. It's been cited nearly 200 times. You know, this is a very, very widely cited piece, and yet we based it on Chinese data and impressionistic stuff, really. And we said that in the article, you know, it ended up in a nice guideline because there wasn't anything else. You know, we were just sort of first off the blocks. And what we said there was, here's some red flags. And these red flags, you'll know them. They're the red flags that we use just in general. They're signs of sepsis or shock, all that kind of thing. So they weren't COVID specific because we simply didn't know what the signs of deterioration were. So you've got the National Early Warning Score 2, News 2, and many of you will be familiar with this picture and plotting, but the data that goes into News 2 is perhaps not the data that you can get very easily if you are a GP as assessing someone over the phone. You know, how do you measure their respiratory rate? How do you measure their oxygen sats when they're not actually in the room with you, and they may not have an oximeter? I mean, things may be changing. The oximeters are now much commoner in the home, but they certainly weren't back in March or April. So let me summarize. In April 2000, we had very high rates of COVID. Hospitals were overwhelmed. Patients were dying, perhaps unnecessarily. Perhaps general practice was overdoing its gatekeeper role, and the recommended tools were probably neither sensitive nor specific, and were impractical. So that's where we went to develop a bespoke score for COVID. Now, this paper by Gary Collins and team, you don't have to read it, I'm just going to summarize what it says, is that there is a methodology for developing early warning scores. They have to be developed, first of all, qualitatively, based on clinical wisdom, and also based on what patients value as important, and then validated quantitatively in properly constructed, what we call inception cohorts. Because if you don't do that, you end up with a score that isn't valid. Okay, so the first phase of this, and this take a bit of talking through, was item development, the qualitative phase. We wanted to develop items for a score that we're calling RECAP. It was actually James Ray that came up with that acronym, Remote COVID Assessment in Primary Care. For patients with suspected COVID who need escalation, so who need to be sent to a hot hub or who need to be sent in an ambulance to hospital. So what we did, we first of all reviewed various topics, such as the efficacy of oximeters, for example. I posted some of them in the chat earlier on. And then we got together 72 clinicians, a total of, and did an online Delphi panel where you put out some draft items based on the rapid reviews, and the clinicians argue about those, and then they suggest changes to the wording of the item, and also changes to the cutoff value. You know, what counts as a high temperature, what counts as a high pulse, that kind of thing. We also did interviews with 20 patients who had the experience of phoning their GP or NHS 111, sometimes very sick. And then we did some online focus groups by Zoom. So we had a lot of qualitative data. I'm not going to tell you about how we analyzed that, but you know, that's what we do. I'm going to go straight to the findings, and I'm just giving you the top 2 rows of what is actually a table with about 15 different items. So there's lots of other items on here that I haven't shown you, because I just want to give you the kind of stuff that we were doing. So for example, pulse rate, we did 3 rounds of Delphi, and you can see that as we went through the Delphi, we increased the percentage of people who agreed that the wording of the item was okay, and that the cutoff value was something that they could live with. And again, with the temperature, you can see that they didn't like the wording at first. 58% of people liked it, the rest didn't. And by the end of it, we were up to 89%. So we did these rounds, and it took us a few weeks to get that done. And this is the RECAP version 0 score. And I'll just talk you through a little bit. I'm not going to go line by line. The first thing is in the top left, there are some red flags, not dissimilar to the ones that I showed you earlier on. There are some things you don't need to fill out a score. If the patient's gasping, if they're in shock or whatever, you're just going to send them straight in. But assuming those red flag questions are negative, we've then got, you know, green, yellow, amber, red, and we can score, for example, the heart rate, the breathlessness, and so on. And all of these items have an alternative in case you are doing it over the phone or by video. So item 4, for example, oxygen saturation. If the patient's got an oximeter, we've got some cutoff values there. But if they haven't, if they're just on the phone, there's no oximeter, we can instead use profound tiredness or fatigue. And for one, we had actually stories about 2 patients who were so tired they couldn't speak. That didn't sound too good. And the stories about those patients were they were very, very sick. So we put unable to speak because of tiredness. And sure enough, those patients were, when properly assessed, very hypoxic. Okay, so that's how we developed the score. And at the moment, it's got 10 items, which is too many to be practicable. So what we do now is we do a scale validation, and that will lead hopefully to item reduction to pick the 5 or 6 ones that are most predictive of a poor outcome. So what we're doing in this second phase, which is just about to start literally on Monday, we want to test the predictive value. We want to test how each item contributes to 3 outcomes: hospital admission, intensive care unit admission, and death. So we get verbal consent from the patient at point of care. They don't need to fill out any forms, but we do need verbal consent for data linkage. And then the recap items have been built into a template on the GP record in EMIS and System 1. And through magic data linkage, which I haven't got time to tell you about how it works, we link those with hospital episode statistics. And obviously, things like death may not happen straight away. We've got death within 56 days. So there'll be a bit of a lag in terms of doing all the analysis. But let me tell you briefly about the 2 sites that we're doing this. One is Oxfordshire via the RCGP Sentinel network. So you can see the green dots. We've got GP practices all over the country, but we're going to start with the ones in that red area, Oxfordshire. They've got to join the RCGP Sentinel network. So if you're a GP listening and you're not in it, email me and I'll tell you how to join it. And Simon Delusignon's team will be leading on those. He runs the Sentinel network. And then we're working also with Brendan Delaney at Imperial, who's got a local integrated electronic patient record, which actually makes it much easier for him to get hospital data and link there. So it's effectively 2 different data linkage studies, which we're about to start. So let me summarize again. We're now in September. We've again got a rise in COVID incidents. You know that. We've got funding and ethics approval for the validation study. Funding's mostly from UKRI, by the way. We have met many times and argued about how to code this. The coding arguments took a very long time. We've agreed them now. We've built the templates, and we are looking for 3,000 patients to contribute their data in order to develop a validated recap score. Our paper describing the phase 1 is under review for BMJ Open. So thanks very much, and thanks to the clinicians and patients who participated, and to the funders.
Thank you, Trish. That was fantastic. Okay, questions. Andrew, you spot any in the chat? I can't spot any for Trish at the moment.
Thank you very much. I'm aware that we're coming towards the end. I'm just going to start with a slightly provocative question for Trish. Trish, 3,000 patients. I'm not sure how well you're going to be able to capture those, but does this mean you're going to be ready for phase 3?
I jolly well hope so, yeah. I mean, it sounds a lot, but actually, the other thing to say is that, as you guys all know, a patient who is very sick and breathless and febrile, while COVID is circulating, may not have COVID. They may have all sorts of other things. And so one of the other hypotheses we're going to be testing is, if we've developed this score to pick up very sick people with COVID, is it going to be less good than News 2 for picking up people who don't have COVID? My instinct is not, but we're in scientific equipoise, and it may be. So those 3,000 patients won't all have COVID, but they will all be sick enough for someone to think they might have acute COVID, if you know what I mean. But yeah, this, we're going to be living with COVID for 17 years. So, we'll be ready for wave 16 or whatever. Oh, someone's asking, were they all GPs who took part in the Delphi? No, advanced nurse practitioners. We had a whole focus group of advanced nurse practitioners. We had a couple of paramedics, couple of ambulance staff. So predominantly GPs, but also other people who assess patients. We didn't use NHS 111 call handlers because that wasn't, that we are interviewing them, but we didn't use them for actually refining this score, because guess what? It's based on clinical judgment.
Trish, is there any sort of consideration to make the recap score visible to clinicians in the hospitals?
Well, I hope so. Now, Matt Inad Kim has got a good line on this, and he says we need a common language of deterioration, a common language of sickness. And one of the downsides, one of the worries about the recap score is that if the clinicians speak news too in the hospital, but the GPs and the paramedics are speaking recap, then there's a problem. I rather suspect, well, first of all, we need to see whether it's valid. If it's not valid, we can chuck it away. If it is valid, I rather suspect it will be stuck on the wall alongside the News 2 score, and it won't be that hard for people to talk about 2 scores. I've got a son who's an A&E doctor, and he says, no, I think the A&E people can probably cope with there being 2 scores. And interestingly, we spent a long time trying to embed this into the EMIS electronic record, the conversations I had with the techie people. And then I visited a hot hub the other day, and the recap score was printed out and stuck on the wall with a bit of sellotape. And I understand that the News 2 score is often stuck on the wall of the A&E department with a bit of sellotape. And yes, it might be embedded into some fancy bit of electronic tricks, but actually it's paper, or it's a chart in the book or something like that. So yeah, I think if it's valid, if it's worth using, I don't actually think it's beyond the wit of the hospital people to start speaking that language.
Great. There's a comment from Lalita. It says, it's great to have alternatives that are feasible for telephone and video consultations. Very welcome for primary care. I wonder if all the speakers would like to get their cameras or videos on, so that we might have the last 5 minutes of a conversation sort of between speakers if there are any questions.
I have to say, Meghna, I'm going to have to leave because I've got to make a recording for a news program at 6 o'clock. So I'm gonna love you and leave you.
I'm very grateful for you to be here. Thank you, Trish. See you again soon. Okay, what I'm going to do then is I'm going to request Andrew to summarize and close, and of course, thank the hosts and everybody else. Thank you, Andrew.
Thank you very much. It's been really interesting, many things in the last 6 months, and the strands that we've talked about today have evolved quite quickly over even the last 3 months. So it's really good to see that. And as Andy Walden and others have emphasized, this has really been based on everybody pulling together and doing things without an evidence base, and yet creating pathways that clearly have an impact, even if we don't have all the qualitative data to support that. The things that stand out for me are the benefits of having a standardized pathway with agreed clinical assessment tools, supported by ambulatory oxygen saturation monitoring, which is a consistent theme, and with or without pocus, depending on resource. And I guess that's a subject for further discussion about how well that resource might be rolled out in terms of training and things. And clearly, some of the things that have worked really well in Reading and elsewhere are the coordination between primary and secondary care. And I know that we've still got work to do on that in our region, and conversations are ongoing to try and make sure we're properly prepared for this next wave. Given that we've got a couple of minutes, I wondered, Dan or Andy, whether you wanted to just speak to that question about the role of pocus and the barriers of or not of training, because that was a question that came up in the chat. How easy would it be if we decided tomorrow that that's what we want to do, to put out there an army of people who are suitably trained?
Do you want to take that, Andy? I think you're probably best to kick off.
Yeah, I mean, so I think it's often easy to conflate things, but actually, lung ultrasound encompasses a whole load of things, and it includes pleural ultrasound and actually ultrasound in the lung, but really the key to why it was successful, why I think it was successful with this GP hot hub, was that we were all we were dealing with was COVID. We didn't have to worry about any other infectious sort of issues at the time. And so we used it in a really simple, like dichotomous decision-making way. So, you know, again, often things get conflated, the difference between point of care ultrasound and departmental ultrasound. The whole essence of point of care ultrasound is that it's a dichotomous decision-making tool. So all we really taught the GPs was, this is what normal looks like. So we got them to scan a few normal people. We showed them what COVID was like, which was very characteristic. And when you're in the middle of a pandemic, if it's normal, it's normal. And if it's abnormal, it's COVID. And that was the approach we took, which sounds very non-nuanced, but actually it worked really beautifully. And then what happened was that these GPs have naturally then become very, very skilled at using ultrasound and have started to pick up other things. So they've, you know, started to pick up pleural effusions. But having some support mechanism was great. Having a cloud to be able to, you know, if they weren't sure, they would email us, and we could then sort of almost real time email them back and go, no, actually this looks normal to me, or, you know, this is definitely abnormal.
So Andy, in a nutshell, aware of the time, quick, medium or long in terms of implementation, if we decided we wanted to.
And lots of potential groups who could do it, like echocardiographers and stuff like that as well, who could just pick it up like that. That's really,
really helpful. I'm aware that we're over time, so we better wind up now. Can I finish, please, by thanking all the speakers? There's been a lot of very positive feedback on the chat, and I'm sure we all second that. It's a really busy time for everybody, so thank you all for giving up your time to share your experience with us, and sharing in both the chat and in your talks your valuable experience. I know personally I've learned even more today, and that will go for many of the people on the talk. Thank you too to Meghana for chairing on your holiday, Meghana. We really do appreciate that. And to the AHSN, Joe and the team for supporting this. We're very grateful for making this possible. And with that, that brings us to the end of this AHSN webinar. We'll probably be looking to do some more on different themes in the new year. Thank you all for attending.
Thank you all. Thanks, Andrew.